the Director of Emergency Nursing Advanced Practice here at ENA. I want to welcome you all and thank you for attending this webinar on invasive bilevel positive airway pressure, or BiPAP. This is a very innovative alternative to ventilatory management and something that we have not commonly seen in emergency care, and it is an alternative for our patients with COVID-19. So we want to thank Syneos Health for working with us here today to present this webinar and welcome our guest speakers. We're very lucky to have Dr. Keith Robinson, who is a pulmonary critical care intensivist at Broward Health in South Florida. Dr. Hugh Cassieri, who is the Chief of Critical Care Medicine at Northwell Health, who unfortunately or ironically today is in the midst of caring for a COVID patient. And so we are hoping he'll be able to join us, but he may in fact not be able to because he is actually caring for a patient with COVID. And then we have Jamie Capiello, a very experienced respiratory therapist who has many years working in the emergency department at Duke University Hospital, who will be presenting with us as well. Each of you has been muted, and we've turned off video today to allow for better bandwidth. But if you have any questions as we go along, please hover over either the bottom or top of your screen at the Zoom toolbar. You can post your questions, and we will be taking those, and we will try to answer as many as possible at the end. If we don't get to your question, we will be following up by email to get you those answers. So, Dr. Robinson, please take it away.
Sorry for the delay. I'm going to get to the first slide. So I'd like to ask everybody that's participating. Again, I'm Keith Robinson. I'm a pulmonologist and a critical care physician in South Florida. Unfortunately, I've had the opportunity to take care of some patients with COVID. And this very first question is an audience response question. We'd like to find, if you're able to answer the question regarding which of the following devices can be adapted to meet the needs of patients in emergency invasive ventilation. Please make your choices. Okay, I think that's probably enough time. Would you like to show what we've got in regards? Perfect. Well, let's give you the answer. So I think when we started this initiative, we were very much aware that there were devices that were at home and hospital devices in regards to utilization of bilevel positive airway pressure. And up until recently, we were aware that only hospital devices could be fashioned in a way to provide the oxygenation, FiO2, or the concentration of oxygen requirements necessary for COVID patients. But there now have been some adaptations that have been approved by the FDA that are now available for home use BiPAP devices. So the top two are the correct answers. So we started this project with the understanding that there was a novel virus coming out of the Far East, China specifically, coronavirus SARS-2. And I think the idea that SARS-CoV-2 is novel is that it's doing things that we've not recognized from a pulmonary standpoint in regards to how poorly patients oxygenate, how quickly they become ill, and more importantly, the secondary or the extrapulmonary concerns that we see with COVID disease. And so I think the time that we first our first patients here, likely into February, first part of March, to now, we've learned so much about the virus and more importantly, how that virus is affecting patients in the United States. And so I'm hopeful that today we're going to be able to update everybody so that you're familiar with not only the presentation of COVID, hypoxemia, but more importantly, why I think, and I'm certain you've all heard that we've been getting away from describing this as an ARDS or an acute respiratory distress syndrome. why we've gone in some fashion away from describing this as a typical ARDS in regards to how we're going to manage these patients. Next slide. So this was our prior paradigm. I think when we first started taking care of patients in the United States with COVID-19, we saw the hypoxemia, we saw the bilateral infiltrates, we saw in some patients no evidence that they had cardiogenic shock or heart failure. And so all the things we would use to diagnose ARDS were present. And so at my facility, and I'm certain that many of the facilities you all work at, we would use a protocol in order to help manage the oxygenation concerns for those patients. And so this staircase that we have here in cartoon is a simple way of describing that, that protocol that we were using. And I think for what we were witnessing at the bedside, we were finding that the ability to improve oxygenation based on this paradigm was not working for a good majority of our patients with ARDS. And I think the idea that in early management, these were things that we would use in order to stabilize a patient, we later found were not the things that were keeping patients with COVID-19 safe. And again, I think if you've been reading the literature, we've swung in the opposite direction in regards to how much support patients require. We've had better discussion about who's going to receive intubation, more importantly, who's going to receive mechanical ventilation. So I think this discussion today is going to be a timely one, simply because we've moved away from using a paradigm such as the one here in management of ARDS and moving more towards the physiology that patients are showing us at the bedside. Next slide. I was concerned, like many physicians here in the United States. I think we were all aware early that the number of mechanical ventilators that were present in the United States were likely to not be at an adequate number in order to keep our patients and our family and friends safe. And so the concern I have as an intensivist is, what will we do on the off chance that I ran out of mechanical ventilators? So the middle of March, my colleague Jeff Stewart and I had a very quick call to discuss what sort of things are present in facilities that are likely to keep people safe. And the one thing we discovered in this initiative were that there were just as many patients who would be on a BiPAP device, a bi-level positive airway device, for other reasons, either COPD or heart failure. And so the question was, could that device be used in an emergency setting to not only help ventilate our patients, but more importantly, to help patients with COVID-19 to oxygenate? And the answer to that question was yes. Next slide. So this is our ask, and more importantly, this was a solution that we had come up with. And I think the idea that what we are asking clinicians and healthcare workers to consider is to utilize that BiPAP device that's already present at the bedside. And I'm aware that many clinicians were afraid of using a BiPAP device because they had been instructed not to. But I think the idea that what we're asking is, when you've run out of tools in your toolbox, what would you use in order to keep people safe? And I'd had opportunity prior to this virus to utilize a BiPAP device as an invasive means to ventilate a patient. I think we've all worked on days where maybe a travel ventilator is in use, or more importantly, patients have had a bad outcome on the floor and it takes time to get them down to the critical care unit. And oftentimes that time will allow for some clinicians to actually utilize the device at the bedside. And so our solution here is, instead of reaching for a mechanical ventilator, after you've intubated your patient, which is what this cartoon demonstrates, you're likely to be able to use that same device that you were using non-invasively to go ahead and start to ventilate and oxygenate your patient, and more importantly, stabilize the concern. And I think what that does is allow for maybe more critically ill patients to utilize the standard mechanical ventilator. But more importantly, we're finding that with COVID-19 patients, many don't require such high pressures. They don't require such heroic means of ventilation on a standard mechanical ventilator, in which the BiPAP device that's already at the bedside is likely to help keep that patient safe. Next slide. So very early on, we had to combat the acronyms BiPAP and CPAP. We had to go across the community of clinicians here in the United States to better define what it is we're talking about, so that in regards to our discussions, we were all on the same page. And so for the purposes of bi-level positive airway pressure, it was important for everybody to recognize, to separate the device from the therapy. And I think the idea that BiPAP therapy in some patients is necessary, and I think some great information is coming from Europe in regards to who did well, who did poorly, meant that we had to help doctors and healthcare workers to understand that what we're referring to is the therapy of BiPAP and not just the device itself, which unfortunately led to some confusion about whether you could use continuous positive airway pressure devices, CPAP devices, which are generally used for obstructive sleep apnea. So for the purposes of what we're discussing using a device that uses two separate levels of pressure in order to support the patient's ventilation, which is the ability to get rid of carbon dioxide, but also be able to provide an adequate amount of oxygen so that that patient's oxygen by concentration can be lowered safely by adjusting the lower pressure, or the EPAP, in order to make that patient oxygenate at a level that's appropriate for their condition. So for us, we've got 4 facilities that are currently utilizing BiPAP devices in a similar fashion invasively in patients with COVID disease. Dr. Cassieri at Northwell. We've got some patients in Mass General who've had the opportunity to utilize BiPAP to stabilize their concerns. We're aware that Emory Health in Atlanta is also utilizing BiPAPs on an emergency need. And then my facility locally at Broward Health, we're likely to continue to use BiPAP devices if necessary. So we want to make sure it's clear that we're referring to BiPAP devices and not CPAP devices in regards to stabilization of patients. Next slide. So I think as that pendulum has swung back from using mechanical ventilators and using ARDS protocols, and then with the concern that we may have caused more injury to the lung and more importantly, watched patients have outcomes that weren't favorable, that pendulum has swung back towards using non-invasive means. And so we didn't want to not include non-invasive ventilation as a means of supporting patients in hypoxic respiratory failure. There is great literature to suggest it's not only safe, it's well tolerated. This literature coming from Italy specifically, some late produced product from China also demonstrating that patients did quite well with non-invasive. So the idea here is we're really trying to provide some level of support to patients so that we can minimize the injury to the lung, or that volume-induced lung injury that can occur with patients when they have a bilateral infiltrate / pneumonia such as COVID-19. So for here clinicians, it's important to remember that you may be able to use a helmet. Helmets are not FDA approved here in the United States, but if I have international listeners, I wanted to ensure that you're aware that if you do have the ability to use a helmet is safe and can be utilized with a BiPAP device, or a simple face mask that we would ordinarily use with a BiPAP can support respiratory status. So the idea, what we're trying to do is minimize any risks that we can to any healthcare provider that's going to care for COVID-19 patients. So if you make another click for me. And we were very much aware that we were going to get pushback from the community in regards to who was going to be safe from a healthcare worker level and who was not. And so our initiative, our solution was to very much make sure that every healthcare worker that was going to care for a patient with COVID-19 was also going to be safe, obviously wearing the appropriate protective equipment, but also minimizing the chances that we're going to aerosolize any of the virus and harm any of the healthcare workers that are trying to help patients with COVID-19. So for us, the initiative was very specific, which was to go ahead and intubate that patient, stabilize the concern, and more importantly, not to wait too long. Because I think when we use non-invasive ventilation in patients that are hypoxemic, sometimes the delay leads towards a rush intubation, and a rush intubation leads towards an unstable patient. And more importantly, a rush intubation also leads towards more aerosolization of virus, which might potentially harm or get healthcare workers at risk. And so for us, the idea was to make that a non-issue by intubating that patient early, and then at that setting, using that same BiPAP device at the bedside so that we can, again, oxygenate and ventilate for our patients. And this, I'm sorry, next slide. And this opportunity comes very specifically because we can use that same device based on its mechanism to ventilate patients, meaning we're just using pressure like a standard mechanical ventilator, and we'll go through the algorithms in a moment. But I think the idea that you can adapt a BiPAP device for an invasive means is important. And I'm going to ask my colleague Jamie, if he could, to help me out a little bit on this slide, because I think the particulars of what we're discussing would require somebody familiar with not only setting up a BiPAP device, understanding how to set up humidification, but more importantly, being able to explain the difference between a single limb passive circuit or a double, which we would use on a mechanical ventilator. So Jamie, I'm going to ask you if you could to maybe explain a little bit of this cartoon for the folks listening.
Well, thank you for the introduction. Yes, let's look over to the left side of the screen. We see the BiPAP pressure source controller. What we have to first recognize is that when we're considering BiPAP, it's bi-level pressure. That means it has an inspiratory pressure and an expiratory pressure. Now we can set this machine for volume, for pressure, for a certain amount of inspiratory time. We're essentially setting this BiPAP device the same way we do these advanced mechanical ventilators that we use in the critical care environment. Each breath delivered to a patient, whether they be actively breathing or passively breathing, it's determined by three things: pressure, volume, and time. So we take this device that we're familiar to call BiPAP, whether it be John's BiPAP machine or Harry's BiPAP machine. If it supports BiPAP, it'll support a breath. We then connect it to a humidifier because we have to give active humidity for the secretion mobilization. But let's stop for a second and recognize that there's one tube going from this BiPAP device to the patient. Mechanical ventilation went years ago to two limbs, a dual limb circuit. And the reason for that is we needed some specific control to monitor exhale tidal volumes. The machine started getting a little bit more sensitive. And so if we could measure flows on the inspiratory side and expiratory side, we can be very sensitive and respond to patients when they're spontaneously breathing. However, single limb circuits never went away. They always stayed from the 80s on. We see them typically in LTACs, at home use, and in the late 80s, they got very positive feedback on using these single limb circuits for non-invasive ventilation. If we stop calling these machines BiPAP and look at them as non-invasive ventilators, whether they be single limb or double limb, it's easy to transition to thought of how this works. So let's go from the BiPAP machine on the left and slide up the single limb circuit after it's passed over that active heater pot, that active humidifier, and it connects to the patient. If we stop over on the right side of the screen and we see a little box that says filter and leak port, what's essential is that the patient has one way to exhale, has a way to exhale. If we look at a single limb passive circuit, or that's what it's being called here, we have to have one way for the patient to exhale. The dual limb circuit, positive pressures on one side and zero pressure on the other side so that the patient's breathing in a circular fashion. In a single limb, however, if we put an expiratory filter, an expiratory valve somewhere near the endotracheal tube or the tracheostomy tube, then how the machine senses the patient's respiratory status or how you've designed the machine to breathe for the patient, it'll relax pressure or volume, and then the patient can actively or passively exhale through this little port. There's a number of different types of exhalation ports, whether they be disposable expiratory ports, DEP, which is typical on most single limb circuits, or swivel adapters, which is typical on most home face mask breathing units, or a mushroom valve, exhalation valve. So there's a few different ports that you can use, but this in particular, which we'll be reviewing, is the disposable expiratory port. Now, these exhalation ports also are built with adapters so that we can filter the air so that the exhaled gas doesn't promote any aerosol generating air that's a danger to the healthcare workers. Okay, next. Next slide.
I've lost control here. So I'll start. And I think what we've wanted to do with this project was to ensure that everybody that would consider using a BiPAP would understand that it was a great task to find literature, as there is a sparse amount in the world regarding the ability to use an invasive BiPAP or non-invasive device. But we thought very clearly about resource poor opportunities, not only in the world, but certainly in a facility. And so when we started using those search parameters, we did find a few papers that actually demonstrated not only the safety of invasively using a non-invasive device and a BiPAP device, but more importantly, that patients improved, meaning that without a mechanical ventilator, standard ventilator, they received the same benefit in regards to improvement of not only their coma scores if they were hypercapnic or with elevated CO2 causing them to be sleepy, their pHs improved, their ability to ventilate improved. More importantly, these were patients who, from a critical illness or SOFA score, also demonstrated some improvement. And so it wasn't too far of a stretch for us to go ahead with this project simply because it's been done. It's been demonstrated to be safe for patients. And more importantly, it shows clinical benefit that many patients will allow them to arrive at a safer point in time. Next slide. So let's talk about the virus containment considerations. So which of these can transmit SARS-CoV-2? And this is again another audience response. And so we'll ask you all to list your answers and we'll go through them quickly. I think that's probably enough time, hopefully, for everyone. I'm going to see what the scores here are. So I think when we talk about how, and more importantly, where this virus can be found, it's everywhere. So the way I describe this for my residents when I work with them, that this virus is like a sand burr. If you've ever gone to the beach and stepped on a burr, it's highly sticky. And so the idea that it's such a sticky virus can have some time to live on either of these type of surfaces means that's why washing your hands are important, not touching your face are important, but more importantly that we've not allowed for any of these objects to not be cleansed frequently in order to wipe down and clear the virus from their surfaces. Next slide. So one of the other issues we had to make sure we addressed was, when we talk about face masks and more importantly, the risk of aerosolization, there are different ways that you can divide and more importantly, provide the BiPAP pressures to patients. Most commonly would be the face mask that you see here in the photo. And I think the idea that we were also, as I stated earlier, conscious of the fact that many clinicians were likely to already be using non-invasive devices on patients meant that we wanted to make sure that after a patient either improved or more importantly, if they were not improving, how will we minimize those risks? And more importantly, has there been study to demonstrate which of the interfaces would decrease that risk to healthcare workers? Next slide. And so this simple table is at least what we've found in the literature in regards to what sort of interventions are likely to be at the bedside. More importantly, what are the risks or the odds that you're going to be exposed to the virus? And so for us, a face mask, a manipulation of an oxygen mask, has a pooled estimate of about 4.6. So that's odds of being exposed to 4.6. That 64.8% is the variance of how wide that variance is, suggests again, technique, maybe location or site, and more importantly, skill of the care worker likely accounts for that wide variance. But intubating a patient, as I noted earlier, also has an increased risk of aerosolization of virus at 6.6. But when we talk about non-invasive ventilation, that risk goes down to 3.1. And I think the idea that you can go from something as high as a simple mask or a face mask at 4.6 down to 3.1 means you're decreasing the odds that you're going to expose healthcare workers unnecessarily. And then add at the bottom there, the intubation. Unfortunately, only one cohort study could be found, but you could drop that risk to less than 1. So the idea here was that in using non-invasive ventilation, not only are you decreasing the chances that you're going to expose healthcare workers, by placing that patient with an invasive tube, an endotracheal tube, you can further decrease the chances that you're going to be exposed to the virus. And so for us, it was, again, not only a way to keep patients safe, but also keep healthcare workers safe as well. Next slide. So let's go through when to intubate. So which of these are potential benefits of earlier intubation? I'll give you some time to answer the questions here. Okay, I think that's probably enough time. If you want to show what everybody thought. All right, sounds like everybody's keeping up with what we're discussing. So if you want to show the answers. So all of these are important. And I think You know, I've been a healthcare worker, a provider at the bedside, many frequent phone calls to discuss the deterioration of my patients. And I think the things from a pulmonary standpoint, everybody should be cognizant of is that when we talk about intubating a patient, one of the reasons we do so is to minimize the work of breathing, how hard the patient is working to breathe. And if you've not had opportunity to take care of a COVID-19 patient in respiratory failure, let me let you know now, the increased work of breathing that these patients display is quite huge. They're working really hard. They're breathing really fast. So the idea that many of these folks may also be working against upper airway resistance, meaning that the tongue or the back of the throat may have a large degree of resistance, and they're trying to inhale against that resistance, means that an increased risk of what's called negative pressure pulmonary edema, which can also worsen your oxygenation, more importantly, worsen your chest x-ray. And it's an important and a recognized reason for many patients to fail non-invasive ventilation with a face mask is that upper airway resistance that's not overcome by the device and interface. And so for us, the idea that we can overcome that upper airway resistance with intubation was important. We could minimize the amount of dead space. Dead space in the lung would primarily be the large windpipe or the trachea. That's about 150 milliliters of volume. And so that's non-participant air. It doesn't help you to ventilate, and more importantly, it doesn't help you to oxygenate. And so by placing an endotracheal tube right into the center of the large windpipe, you're going to be able to not only oxygenate patients more efficiently, you're also overcoming that non-participant dead space of air that's within the lung that's not helping patient to improve. And I think lastly, the things that I would worry about as an intensivist are comfort. The idea that we're going to be placing patients onto a device that's likely to make them feel like they're suffocating, which is what a face mask feels like for some patients, means that we can now give some level of comfort to our patient, meaning sedatives, so that again, we can better control the comfort level of a patient. We can minimize the risks of aspiration by protecting that airway by giving comfort medications. More importantly, we can allow that patient some rest. And I think that's what many of our folks are finding is that when they take care of patients with COVID, these are folks that have been working and struggling for quite some time, and they do require some rest so that they can heal. So next slide, please. So I left this slide fairly blank on purpose. And I think the idea that every facility, every hospital is going to have their own algorithms for how to sedate patients means that this is something you all will have to fill out on your own. I think all available options are on the table when we talk about keeping patients sedate. And the one pearl I would share with everyone is that COVID patients are extremely hard to sedate. And we don't know why. And I think that's something we will learn on the back end of this virus, which is why that is the case. And that's the other reason why there aren't any specific recommendations here on the slide. But we've had to use in some patients 3 to 4 agents in order to keep them comfortable on a mechanical ventilator. So I think the idea that you're going to have to find what's available in your local facilities is why this slide looks so sparse. But all options are on the table. Next slide. So we're going to go quickly through the algorithms and the device settings so that everybody's familiar with how to utilize a BiPAP. And I think in consideration of patients with COVID-19, we really want to make sure that we've assessed for any of the concerns. And I'm going to ask Jamie again to chime in here because, again, I've placed the order for BiPAP therapies, but there are things at the bedside that many clinicians need to be familiar with.
Thank you, doctor. So we have treatment targets on PaO2 greater than 55 millimeters of mercury, saturation greater than 88%, and a blood pH of 7.35 to 4.5. What we have to recognize is that these are treatment targets, and they're not absolutes. Although the PO2, the SAT, and the blood pH are reflective of whether we have good metabolic function and that the patient's interfacing well with the mechanical ventilator or the BiPAP device, we have to recognize that the most important thing is, did we fulfill what we wanted to do just two slides ago, which is make the patient comfortable and improve oxygenation. So we have the machine set at certain parameters, volume, pressure, FiO2. We have our treatment targets that we see in our blood gas, but how does the patient look? Is the patient's work of breathing less? Is the patient breathing still 30 times a minute? Are they anxious? When they go to inhale, does it seem like the ventilator is supplying the gas fast enough. So these machines, although they're called BiPAP machines, are full service machines and actually have waveforms on them just as well the critical care ventilators. And so you can observe the patient's diaphragmatic excursion, their chest wall movement, relative to the flows and the pressures and the volumes that are going in and out of the patient. So it's very important that your patient is synchronous with the ventilator. That's the best way to determine comfort, along with hitting these treatment targets. Okay, next slide.
Next slide. So I think if you focus here on the orange area of the slide, what we're talking about are patients with a mean SOFA score. Mean SOFA score, many of our patients with COVID-19 have been in the facility more than 48 hours, in which case you can go back in time and determine how sick the patient has become if they're reaching critical illness. And so the mean score is what we recommend in regards to not having too moribund state where they likely, unfortunately, may require a standard mechanical ventilator. We certainly want to make sure that we've included patients with COVID-19. We are learning that as patients and more importantly, families avoid hospitals, they're coming in just as sick with other conditions. And so I would expand this to include patients who are coming in respiratory failure, especially if you're running low on mechanical ventilators at your facilities. But those considered for use of non-invasive. So anytime you've thought of using a non-invasive device, please consider utilizing our protocol of using an invasive means of oxygenating patients. Moderate ARDS is a PF ratio of 100 to 200. So the P is the PaO2 on your arterial blood gas. The F is the FiO2, or the concentration of oxygen that's being provided. So you divide those numbers, and that's where you get your ratio. Obviously, we want patients to be hemodynamically stable. And more importantly, we want to make sure that what you're watching at the bedside is not a chronic illness that's an exacerbation. So for most folks, if they're coming in with just COVID-19 concerns, this is likely to be a great paradigm and an algorithm for them. Next slide. So this is what we call the smart BiPAP. So this is the algorithm for patients that have devices that can do a mode of ventilation called AVAPS, or average volume assured pressure support. With you reviewing the blue areas of the algorithm, that'll tell you the setup and more importantly, the titration of the device. So in general, you're gonna set a minimum pressure and a maximum pressure. So Pmin, Pmax. I've given some suggestions of where to begin. And more importantly, you're gonna set an EPAP. An EPAP level on a BiPAP device or a non-invasive device is similar to PEEP. And so you can adjust that based on need for oxygenation improvement or comfort of the patient. Generally, we would start at 100% oxygen concentration. And as I noted before, the minute ventilation for our patients can be quite high, upwards of 15 liters per minute. And so you may want to try initially until you've had the opportunity to sedate your patients or provide comfort to try and match what they're doing so that they're not feeling struggled for reaching air that's comfortable. And then we would suggest staying within the ARDS parameters of at least initially 4 to 6 cc's per kilogram, or 4 to 6 milliliters per kilogram. But from there, you want to make sure you've chosen the right Pmax setting, looking specifically at mean airway pressure, keeping that less than 30. You want to make sure that you've adjusted your pressure support as necessary to the tidal volume that's appropriate, again, at that 4 to 6 milliliter per kilogram range. And then you want to make sure you've achieved your oxygen saturations. And I think for safety, we've suggested an oxygen saturation of greater than 90% or a PaO2 on arterial blood gas of greater than 60. Jamie, do you have any other suggestions or things you'd like to make comment on?
Yeah, just a point. If anybody's worked in the critical care environment, this is a mode similar to the large ventilators called PRVC, pressure regulated volume control. The AVAPS mode itself, it has a little bit of delay in changing tidal volumes. It watches for breathing over a minute before it starts to escalate up if the volumes are not high enough, or decelerate down if the volumes are too high. So you have about a minute of waiting for the volumes to change. It's very similar to pressure regulated volume control. It's really an excellent mode for somebody that has a fairly good, you mentioned it before, the slide previous, where less than 2 or less than organ system failure. It's an excellent mode.
And next slide, please. So I was also cognizant of the fact, and if you've worked at multiple facilities, not every facility carries the same type of devices. And more importantly, some facilities haven't bought new equipment in quite some time. And I think for our folks in rural America, this may also be a concern where the type of BiPAP devices that are present are likely not to have AVAPS mode. So we also have an algorithm here for just the ST, or the spontaneous timed mode of ventilation. And in the blue box here, again, more suggestions of where to start, not the settings that you end with, but the settings that you would start with. So here, an IPAP, or that inspiratory positive airway pressure of 8, and EPAP of 4. For me, that's comfort. I've witnessed, unfortunately, some patients having IPAPs and EPAPs set early too high, in which case patients aren't comfortable or they're asynchronous with the device. And so using lower pressures and titrating, again, the IPAP to a level of tidal volume that's appropriate. And again, 4 to 6 milliliters per kilogram is what we suggest is appropriate. Because I think in that titration, you're gonna hopefully find the work of breathing comes down, the minute of ventilation stabilizes, and then you can assess your patient. I think the caveat to both of these algorithms are you're gonna want early arterial blood gases to make those adjustments. I've made the suggestion of 30 minutes simply because we don't want folks to not show signs of stability, or more importantly, that you haven't had an opportunity to go back by the bedside to improve the condition of the patient. But again, Jamie, if you have any other pearls you'd like to share, I'd be happy to hear them.
Yes, in the previous mode, the AVAPS mode, we're targeting a tidal volume, and the machine is going to adjust pressure in order to aim to get that tidal volume sought after. In the BiPAP mode, this particular device, the IPAP and EPAP, for those of you that are familiar with the big mechanical ventilators, this is the driving pressure is different for these BiPAP devices or these non-invasive ventilators than it would be on the invasive ventilators. Driving pressure on this is typically the difference between EPAP and IPAP. So if I have my IPAP set at 8, my total pressure delivered to the patient is going to be 8 centimeters of water pressure. My drive pressure is then going to be 4 centimeters of water pressure. If I had this on a regular critical care ventilator, the total pressure on the regular critical care ventilator would be 12 centimeters of water pressure. So be active monitoring the tidal volume displayed on these devices so that when you're initiating IPAPs and EPAPs, you're recognizing that your pressure levels are going to be higher than they are with the critical care ventilators, although your total pressure delivered to the patient will be no different. It's just recognizing that difference, that the driving pressure is on these ventilators, the difference between the IPAP and the EPAP. I hope that makes sense.
It does. So, I think that's exactly right. So if you're familiar with the term of pressure support, what we're describing is also pressure support. So that difference between IPAP and EPAP gives you a pressure support. So if you've used pressure support mode on a standard ventilator, not too different in its ability to ventilate a patient. So next slide, please. So these were slides that I'm going to let Jamie take over. They come from Dr. Cassiari's slide deck, and unfortunately, he's again taking care of a COVID-19 patient at the moment, so we may move through these quickly. Next slide.
All right, perfect. So these are the 3 individuals that were behind this Northwell use of the V60 for their invasive mechanical ventilation. And I think Dr. C wrote a really nice protocol and does a great job in explaining the protocol and giving us good hands-on slides. We'll look at the first slide here. What they're holding is a test along with 2 filters. All right, so you switch, yeah, with 2 filters. Keep in mind that this, I don't know if you can see my cursor, but those 2 filters, one is to prevent the exhaled gas from being transmitted out when you possibly have to disconnect the patient. It's a safety valve that most places have gone to. The other dark gray filter is to decrease the transmission from the exhaled gas as well. And you have a thin little white line, and that's a pressure manometer. A little thin little clear tubing is a pressure manometer, and you see the white tubing held in that fellow's hand. That's the single limb circuit. Okay, let's go to the next slide. So their experiences were first on COVID-19 respiratory failure patients, and it freed up the regular FDA-approved invasive ventilators. I want to make note that the V60 that they used was actually FDA-approved for invasive ventilation, but none of us in the healthcare community ever used these as invasive ventilators. Probably some people did somewhere along the lines, but they are typically looked at just as non-invasive ventilators. And so over the course of 3 weeks, they ended up ventilating invasively 50 to 60 of these patients. They still have 12 to 15 patients on these devices. During their second surge of the COVID-19 patients, again, they were depleted of ventilators, all right? And they use this protocol or these protocols that we're talking about to rescue these patients who needed advanced mechanical ventilation. And when we look at these patients in severe refractory hypoxemia, we call it, the typical way that they are presenting is severe air hunger and hypoxemia. If we give them positive pressure ventilation, it decreases their work of breathing, and then we can supply them with a specific FiO2, an increase in their tidal volume, and a little bit of PEEP to improve their FRC so that they oxygenate a little better. So we're making them much more comfortable. We're allowed to sedate them, and we're allowed to give them an increase in their mean airway pressure so that they don't have to work as hard. Their third experience ended up with 80 patients using the V60 for invasive ventilation. So it's really phenomenal numbers that they're looking at, and quite a support when nationwide we were screaming for ventilators. Okay, next slide. Now here's the particular setup. If we look on the left, note we're really looking for trying to keep patients and care providers as safe as possible. They have a HEPA filter on the outlet port. The top clear tube is the pressure manometer so that we get nice sensation of how the patient's breathing and when the patient's breathing. So it goes into a single limb, and we move over to the right slide. And this is a close-up of the exhalation disposable expiratory port that we spoke about earlier in the single limb circuit slide. The bottom is, that bottom rectangle is another HEPA filter. All the way to the right, that's a tracheostomy tube. And so the exhalation port or the disposable expiratory port, they have connected directly to the tracheostomy tube. So this is just a nice schematic of how the air would go in to the tracheostomy tube and come out. And because this is a known leak, the single limb circuit is going to depressurize the breath and allow the patient to only exhale one way, because the single limb circuit is going to keep pressure greater than how the patient's exhaling. Okay. Make sense? Next slide.
Yep.
Here's how the device is set up. Note I said earlier that it's FDA approved. When the V60 first came out, there was a little delay in FDA approval because they wanted to get it approved for invasive mechanical ventilation. And you see on that left screen a little box that says ET trach. What you're doing is telling the machine what kind of patient you're ventilating and how much leak is supposed to be observed by the machine. So here they have it set at ET tube or trach, so that the machine now can recognize the leak. It's quite a smart device. The next thing you need to set it up is you need to tell the machine over on the right, pardon me, what kind of exhalation port the patient is using. Whisper swivel I mentioned, DEP is the particular port that they're using. PEV is another active expiratory valve that's used for another type of patient. And then other would be, if you don't have either one of them, but another non-Respironics exhalation port. So this particular setup would be DEP. Okay, next. And then there's an exhalation port test to make sure that the machine learns its initial leak. You occlude it, it does a little pressure testing. It measures the leak on the exhalation valve. And so now the machine is going to be sensitive to the patient that you'll put it on. Okay, next slide. So the next screen that you'll see on the machine is you can either repeat the test if you didn't like the results of it, or you can start ventilation. And in order to start ventilation, you actually have to choose what mode of ventilation. CPAP, we know, doesn't provide any ventilation, it just provides PEEP. So if you have a patient that needs respiratory support, you obviously don't choose that. The other three modes that are available are AVAPS, ST, and batch pressure control ventilation. So AVAPS we went over earlier. It's a volume targeted mode of ventilation that'll move between set pressure parameters, no less than X, no greater than X times 2. And it'll set a rate and an inspiratory time to deliver the set flow. The ST mode of ventilation, you'll be setting a rate, inspiratory pressure and an expiratory pressure. This particular machine calls them IPAP or EPAP. And then you can choose batch PCV, which would be typical to standard to pressure control ventilation. Next.
Jamie, sorry to break in, but we do have a question about how you would monitor plateau pressures on AV-APS. So I thought maybe you wanted to answer that now.
Okay, so AVAPS is depending upon how the patient is breathing, if there's active or passive. Plateau pressures can really only be measured in a passive patient, but we consider the driving pressure, the peak driving pressure. That's a surrogate for plateau pressure. So if the patient's getting a tidal volume goal of 500 mLs and the pressure to deliver that 500 mLs was 20, and the PEEP set was 5, the plateau we would consider at 15, the difference between the two. I hope that answers the question.
Thank you.
Okay, so here we have a picture of the batch ST, batch pressure control ventilation settings that Northwell is using. We have inspiratory pressure set at 20, the respiratory rate of 12, inspiratory time, 1 second of breath is pressure over time to activate a volume. We have a rise set at 3, and that's just how fast the breath is going to initially go in. It's kind of a comfort mode that gets adjusted, how active the patient is breathing. We look below, we see EPAP of 7 and FiO2 of 21%. So if we stop at IPAP and EPAP, 20/7, the drive pressure is 13 centimeters of water pressure. If that was an invasive, typical critical care ventilator, that inspiratory pressure would be a little bit higher. That IPAP would be higher. So in this particular patient, total, pardon me, total pressure delivered is 20 centimeters of water pressure per breath. And it's brownish gray. When you hit the activate batch change, it turns to blue. So those are your active settings on the right-hand side. Next slide.
Yeah, you might be able
Dr.
to skip the 3D printing slide. I think we'll move ahead to the next slide.
Well, just let me give you a quick note on that 3D printing slide. These circuits, these single limb circuits, are not common. Some facilities use the Respironics equipment and some don't. If you don't use the Respironics equipment, they're aftermarket pieces. And I'm getting the impression that because everybody started farming out their equipment to be 3D printed at facilities that had the capability, that they use aftermarket disposable expiratory ports, and that they 3D printed these ports so that they had enough for each individual patient.
Great.
So the equipment used at bedside during invasive BiPAP, if you take a look at those 5, they are the standard pieces of equipment that we use for invasive mechanical ventilation. Pardon me. So suction devices need to remove pulmonary secretions, whether you use inline suction catheters, highly recommended for these patients. You need to have suction device not only for the mouth, but also for the endotracheal tube. Pulse oximeter, continuous monitoring of oxygen saturation is essential, no different than you would in other critical care machine. Bag valve mask or an ambu bag should always be at the bedside. That's your backup source for mechanical ventilation. Right? A telemetry system, patients on positive pressure ventilation that requires support from these machines should always be monitored for their blood pressure and heart rate. And capnography, if available, is capable with the single limb circuit. Next slide. So the American Association of Respiratory Care, when ventilators came in short supply, they came out with recommendations for BiPAP use, as well as many state boards came out with recommendations for BiPAP use. What we want to do with ventilator support is target the tidal volume to 4 to 8 or 6 mLs per kilogram of ideal body weight or predicted body weight. We've been over these a little bit with the target goals for mechanical ventilation. Saturation is 88 to 95%. We monitor arterial blood gases for CO2 and pH. We see capnography is not necessary, but if you have it, it's an outstanding disconnect alarm. It is your first source of disconnect alarm, better than the ventilator even. Hit the next, we'll bring up the other considerations. And they have other considerations. When we say titration and physical assessment, it's very important that the machine and the sedation are adjusted for respiratory comfort. Right? We're looking for patient ventilator synchrony. If the patient and the ventilator are cooperating, some of us might think back to terms we've heard, bucking the respirator. If we look at cooperation between the two units, then we can assume that it's just like you or I, where my lungs are breathing just happened for me right now. The same thing with invasive mechanical ventilation. Only you have the caveat of now it's positive pressure, and you have a piece of plastic in somebody's throat. So there has to be some degree of sedation on board, and recognizing whether or not the vital signs are corresponding with the comfort and if the patient's oxygenating well. And note secondary driver or device backup, that is your ambu bag. An ambu bag must be available. Analyzing blood gases, we see TcCO2. That's a transcutaneous CO2 monitor, and the other one is end-tidal CO2. Both excellent devices. And any other safety considerations you may have. And typical ongoing management should be no different than the regular mechanical ventilators, clinical populations such as pneumothorax, gastric distension, and close observation of those lung protective strategies of pressure, volume, and FiO2. So, Doctor, you're up.
All right, thank you much. So I think the idea that we're creating critical care units in some locations of a hospital that aren't familiar with taking care of critical illness and more importantly, critically ill vented patients, that's what this slide is intended for, which is unfortunately some patients are going to be in the emergency department and unfortunately have to stay there for a period of time until a bed frees in the ICU. So you want to always monitor for signs of treatment failure in the emergency department until they get upstairs or downstairs, depending on your facility. But I think the idea that things that we would do, and this is just quick caveats, are that we would prone patients if they have refractory hypoxia. More importantly, we would use paralytics just like any other patient if they had refractory hypoxemia. But anytime we're reaching towards proning, or more importantly, using a paralytic, I would probably view those patients as having more significant organ dysfunction and reach for a more standard mechanical ventilator. And more importantly, if the patients are becoming hemodynamically unstable, they should likely be in the intensive care unit as well. So we're at the conclusion, and I want to make sure we have enough time for questions since we're running slow on time. But BiPAP machines are available. They're familiar. We found that many facilities had just as many BiPAP machines as they did ventilators, so doubling the surplus of what was necessary to keep people safe. You can use them as an emergency tool. Again, we don't want to leave anything left behind in patients who are becoming sick. And if you've got the opportunity, or more importantly, if you need the opportunity, please feel comfortable using your BiPAP devices, as they likely will save a life. And then, again, I think the idea that you're going to be wearing PPEs, meaning you're going to be protected, I've hopefully demonstrated that there are ways that you can minimize aerosol concerns so that, again, in the proper PPE environment, you're likely to hopefully decrease chances of being exposed to COVID-19. These are some familiar web pages. Again, if you'd like to find more information about what we were discussing today. And we did include the references for every amount of information that I've discussed today. So I think I'll send it back to the folks at ENA for any questions. Thank you for your time.
Well, I want to thank our speakers for this very informative presentation. The webinar has been recorded and will be available to attendees, and we're going to put that on our social media for ENA following the event. And you'll also have available a PDF of the slides. So let's go ahead and get to some questions. I do want to say, if you have questions, we have seen on the ENA huddle a lot of conversations from emergency nurses concerned about this ongoing ventilatory management in the ED. This just really points out the importance of collaborating with your physician and your respiratory therapist as a team. And we realize that this is a learning curve. So if you have questions about the process of ventilation and some of the things we've discussed here, please send those questions in and we can follow up with you. Also, past President Jeff Solheim has been putting on some webinars about the basic concepts of mechanical ventilation that you can find on the ENA COVID health, page there. So let's get to some questions. Do you recommend the use of the largest endotracheal tube possible to help with an airway due to the swelling?
Well, I'll take that question. So from a pulmonary standpoint, we generally use the pinky of the patient to decide what size tube should go into them. That's kind of a rule of thumb, no pun intended. I think the idea that we would like, and you should have, because of suction needs, the safest endotracheal tube that can be placed. Means that you're likely to find or utilize the largest one that will fit comfortably. We don't routinely, in the early setting of patients with airway compromise or respiratory failure, see swelling, only if we've damaged the airway by placing a tube that's too large. So for me, I think if you look at the pinky size of the patient that you're looking to support by intubation, that'll give you a rule of thumb of what size tube to use.
Thank you. And is higher level CPAP better than BiPAP, even with invasive airway management, because it maintains a higher MAP while protecting and helping to reduce lung injury?
So I think the idea that CPAPs can, in some patients, allow for not only a decreased work of breathing, but more importantly, have enough pressure in order to allow patients to take in an adequate tidal volume is recognized. I think the concern that we have is that in patients with COVID-19 and ARDS physiology is that they become hypercapnic. They have an increase in the carbon dioxide level that may not be countered by using a CPAP device alone. And if I use sleep, and again, I'm not suggesting this disease is anything like a sleep apnea or sleep concern, but if you have a patient that has a sleep disorder where they have increased carbon dioxide, you would reach for a BiPAP device in order to help to ventilate that patient, in order to help them to exhale or blow down the carbon dioxide that's being retained within the lung. And so that's why we've moved away from using CPAP devices, simply because in some patients, the degree of hypercapnia or elevated CO2 is too great for a CPAP machine to ventilate a patient.
Thank you, that's very helpful.
Yeah, and if I can also add, the question might have been asking, doctor, once they're intubated, could you just use CPAP rather than pressure support or pressure ventilation? I think the answer would be, as long as you're keeping tidal volumes within the predicted range and pH where you want it, and FiO2 or PO2 where you want it, that it's not so much the mode as it is the ventilatory parameters being monitored and delivered safely.
Thank you, Jamie. The next question. I see you are using HEPA filters on the exhalation port of the circuit and at the machine. Can just viral filters be used in those areas?
Yeah, I'll take that. That's a yes and no answer. The HEPA filters will last close to 24 hours. They're hygroscopic also, and they hold a lot more volume than the typical viral filters that you might see on the inspiratory limb of these ventilators. So yes, they can be used. However, they need to be changed out much more frequently. One of the reasons why we aim for these HEPA filters is because if they get too wet, they can provide some expiratory resistance, and that's where monitoring the expiratory limb is important. So if you use the straight, small viral filters, they tend to moisten up after about 6 hours and need to be changed out frequently.
Has there been any thought to containment fields to permit aerosol treatments or BiPAP? In the olden days, oxygen tents were used. A similar barrier system would theoretically limit the contamination or aerosolization.
Well, we are seeing across the world that there are, in local pockets, the ability to utilize a barrier. And I think if you don't have a negative pressure environment, as most of these COVID patients should be placed after intubation or even on non-invasive, I think I would defer to your local environment to decide whether you have the tools at the bedside necessary to maybe minimize the aerosolization risk. But again, we've tried to decrease that risk as best we can by utilizing not only the non-invasive device, but intubating that patient. So again, those odds of aerosolization really start coming down to about 1 when you use those means.
Great. One more. Can you comment on added dead space and increased airway resistance with inline HME? I'm not sure what HME is, so maybe you could explain that. Do you recommend the use of the largest endotracheal tube possible to help with airway due to swelling? I think we covered that already.
Let me just touch on the HME. There are many institutions that almost exclusively use HMEs for the first 72 hours of mechanical ventilation. The HMEs offer a good amount of moisture to the airways, and so it's not so much the HME that's a problem. The concern about dead space, there are only about 25 cc's of dead space, and we look at how we're monitoring the ventilatory parameters, and the fact that these are fairly consistent flow systems. So the resistance is overcome by the pressure of the breath. it's really overcome by the machines. When we first started using volume ventilation that didn't have responsive flows for the patient, yes, we were worried about the resistance, but now the HME is very, very low resistance and can be used up to 3 days. I hope that helps.
Good, thank you. And then we do have a question about high flow nasal cannulas as well, and whether that might be considered as a step before BiPAP or in replacement.
So I'll take that question because there are new suggestions in the literature and as well as from clinicians at the bedside taking care of COVID-19 that the high flow nasal cannula may negate the need of not only intubating a patient or in some settings utilizing a BiPAP or a non-invasive device. But I would make comment that when you get to higher flows on a high flow nasal cannula, the risks of aerosolization don't go to zero. So the higher flow necessary to oxygenate a patient can increase the dispersion distance that we see in utilization of the pressures necessary and the settings necessary to oxygenate a patient. So while they may stave off the need for intubation and in some, and more importantly, may prevent some from going into respiratory failure due to hypoxemia, that does come at the increased risk that at higher flows to achieve those goals, you're likely to have greater dispersion of virus.
Right, so there's always that risk versus benefit in keeping our healthcare providers safe.
That's correct.
Well, we're at time, and I want to thank our colleagues at Syneos for working with us to bring this presentation to the membership and to the emergency care community. I certainly want to thank Keith Robinson and Jamie Cappiello for this very informative information. And again, the link to the webinar will be available on social media. We'll get that out to you as well as the PDF of the slides. Thank you very, very much.
Thank you all.